My name is I'm an extended scope physiotherapist working in Brighton. Set up the virtual fracture clinic in Brighton in 2013. And this is my colleague James Gibbs, who's going to go through some of the beginning part of it. He's one of our orthopaedic consultants in the trust. And we've also got one with us, Sophie Richardson, who's a Microsoft expert, who can field any kind of technical questions at the end of the talk. So I'm going to do a little bit of a fun thing here, break up a little bit. So I want you to think of a time before Wi-Fi. Okay, I had to actually look up when Wi-Fi and the internet was really prevalent, and this is before 1991. Okay, so put yourself back in time a little bit before the mobile phone, when you had to still make a phone call to call your friends. You were dressed in clothes, maybe like this if you were going for the vibe, and you were still listening to Bon Jovi on cassettes. Now I want to think about bringing yourself forward and thinking about how digital solutions have really made life easier for us. Okay, online shopping, it's smart, interactive, it's constantly evolving, it knows what you want, it puts extra things in your shopping trolley at the end of your checkout, looking at your trends. Buying car insurance, you can compare multiple streams of information in one place before you make your decision to what to buy. And my favourite this week is the train line. I don't know if anyone booked their tickets up to Manchester on the train, but you get a handy little text to say, don't forget your umbrella, it might be raining. I don't think they got it right today, but it's interesting anyway. So what do all these services have in common? Anyone out there, go on. What do all these things have in common? So they're online, but they're also designed around the user. So the person who accesses them is designed from the bottom up, what we really need from the technology, rather than thinking about perhaps the NHS, which is designed potentially some services from the top down. So these are two little pictures, just kind of used a bit of a spoof really. But despite vast leaps and bounds in technology within the NHS, we're still struggling to harness even the simplest of technologies to make life easier for our patients and to improve access to our services. I don't know if anyone's gone to physio recently. If you had a stick man drawing, this is quite common throughout physiotherapy. We're in an online technical world. You get a stick man drawing for your exercises, you're meant to know what to do. It's still quite crazy in that sense. You also get a letter for your appointments, okay? So say you've been waiting 12 weeks to come to your appointment, you get this letter, this vital date. It's your friend's wedding on that day. But trying to change that date, I don't know if anyone's ever tried to come through an NHS call centre to change a date of an appointment, it's impossible. So it's all these restrictions that we have that we really shouldn't have in the age of digital technologies. So I'm sure I'm not the first person to mention the 5-year forward. I've already heard it in a couple of talks today. It seems to be quite bantered around. But one of the second key aspects of the NHS 5-year forward is next we reshape care delivery, harness technology, and drive down variations. Safety of care of patients is going to go unmet in the futures, and unacceptable variations and outcomes will continue to persist in the NHS. So I'm now going to pass you over to my colleague James, who's going to take you back in time to a date of the 2nd of April 2013. So come back with us in this journey, James.
Thanks, Lucy. So my job here is really to explain how the traditional fracture clinics worked, where we came from, and then later on Lucy will talk about the changes that we've made and the changes that we're intending to make. So the most important thing for this is really to understand how the traditional fracture clinic works. So as many of you may already know, you would sustain an injury, you would attend the accident and emergency department where you'd be seen by a healthcare professional. In all likelihood, you may be placed, if you've sustained a fracture, for instance, to your lower limb, you're likely to be placed into a temporary plaster, given some crutches, and made an appointment for a fracture clinic, which is likely to happen a few days down the line, where you'll then be seen. And it's only really then that your treatment would actually, your definitive treatment would actually start. At that stage you may be seen by a junior doctor, and certainly in most places I worked as a junior doctor, there was no standardisation of care, and junior doctors, being more junior by definition, tend to over-investigate and over-treat. And it must be remembered that in the fracture clinic, you are dealing with injuries that do not require an operation. So the natural history of these injuries is they're going to get better on their own, they're going to heal on their own, and to my mind, the whole idea of the fracture clinic is empowering the patient, rehabilitating the patient, and getting them back to normal function as soon as possible. So what we wanted to consider is, was what we were doing patient-focused, cost-effective and evidence-based? And it was none of those things. And so we decided to implement changes. Before we did that, Lucy, towards the end of our time of running a traditional fracture clinic, engaged with the patients. And what we noted here, the big thing for us was that only 44% were given, or were only 44% of patients remembered that they were given any advice on exercises and rehabilitation and what to do to get back to normal function. So, drivers for change, well, there's drivers on a national level, and clearly there's a lot being said around this conference on working smarter and reducing costs. On an organisational level, the fracture clinic tends to be the busiest clinic in any orthopaedic department, often with prolonged waiting times. It's a huge burden on any busy orthopaedic department, and what that incurs obviously burdens on physiotherapy as well. And on an individual level, people, as I said earlier, tend to be over-managed and care is fairly inconsistent, and people have to take a lot of time off work or a lot of time out to actually attend fracture clinics. So the objectives that we set out were to improve the overall patient experience, and that was the main thing for us really, and also to avoid unnecessary visits for patients to the department. And the big way to do this for us was to standardise patient care. The other thing we wanted to improve on was that the patient receiving the right care from the minute they attended the accident emergency department. So that involves for us not using things like traditional plaster casts. We also wanted patients to have a single point of contact for when things, for when they felt they needed more reassurance or advice. And we wanted patients to self-manage, and we want to empower them to rehabilitate and to return to function as soon as possible. And we also felt, because the majority of these injuries really only need rehabilitation, that service should be physiotherapy led. And I'm going to hand back to Lucy now to tell us how we did that.
So how we did this and how you should do it aren't necessarily the right thing, but I'll tell you how we did it in a realistic way. So back at the end of August, after a bank holiday weekend, we decided to cancel all of the fracture clinics. I don't know if anyone would know what that would be like, and change to a virtual model over a weekend. We literally jumped out of our fishbowl and into the unknown and decided we're just going to throw ourselves in. From concept to a realisation, we started talking about this at Easter that same year, so we just had about 4 months before we changed the service, which was actually in the NHS, a really quick time frame for making any changes. We changed everything, and yes, I'd say we were working smarter, but I was definitely working harder for the first 9 months. So the way that we really made this virtual is that we basically stripped out anything that we could do to do with paper. So we're completely paper light, apart from patients who can't access our information online. So this starts right back to the journey from an A&E. The A&E consultants or the nurse practitioner, if you've seen them, can refer a patient online. Okay? So we have 2 A&E departments at Brighton and a couple of minor injuries units, and GPs can also refer in to us for patients who've had injuries outside the area. So everything comes in centrally electronically, so there's a record of all of the information. There's no trying to understand doctors' writing, or not knowing who sent the referral, or not understanding where the audit trace is for the information. When we first set up, we excluded paediatric patients and hand and wrist patients. We now have a service for the hand and wrist team, and we're looking to develop it for peds in the new year as well. We just, for non-NHS people, NFA is no fixed abode. We have quite a large population in Brighton of no fixed abode. Obviously they can't be managed virtually, so we had a backup system for them, and then we managed directly while they're in the A&E departments. Patients were given information at the time when they were in A&E, so they were told that they'd be referred to the virtual fracture clinic. They were given a business card similar to the ones that are on the chairs, which gives them the information in detail about how they're going to be attached, how they're going to be attended, and how to contact us if they feel they need to get in touch with any questions before we contact them. And then every morning we have a consultant virtual fracture clinic review. So in traditional practice, you'd have had to come to hospital, take time off work, somebody's probably taken time off work to take you there. Now this happens while you're still in bed, literally about 7:30, 8 o'clock in the morning. The consultant and the physio goes through all of the referrals that we've received in the last 24 hours. And we diagnose based on x-rays and the information that's given in A&E. We have standard rehab pathways for the majority of our injuries, and the decisions are made for the case. So for example, this is an ankle fracture. It looks to be a stable ankle fracture, so we know that this patient can be managed in a boot. They're allowed to weight bear, and we know that we want them to come back in 2 weeks for a weight bearing x-ray, which is what our clinical practice is. So in traditional practice, you'd just come back to the next available clinic at a time that wasn't convenient to you or your injury, but potentially not much to be done. So we're timing things much better. We currently just use an Excel spreadsheet for collecting all the data, which is good because we managed to keep an audit trail. We know all the types of injuries that we've treated over the last 3 years. We can look at trends, and we've used this for research. Okay, but in the future, I'm going to show you how we're moving away from a spreadsheet, which isn't the ideal way of keeping patient data. And if anyone from information governance was in here, they might not like this very much. So what we do now is we have the virtual consultation in the morning while you're still in bed, and then you receive a telephone call from one of our very trained and skilled physiotherapists. They confirm the diagnosis of what you've been given and just check that there's been no other injuries that we've missed, you've not woken up the next day in pain at a random place, and explain to you the rehab pathway that you're going to be going through. And then to tell that you've got all this information supported by videos that are on YouTube, so you get sent an email straight away which has your individual rehabilitation plan for the next 6 weeks. So I've kind of butchered the NHS logo here, right time, right place, right care, and said, okay, yes, exactly, that's right, but we don't need to be holding people's hands anymore. We can use digital technologies to be there within the comfort of their own home and to save them having to come here to handheld them through the process. So basically we have 27 rehab videos for the majority of our types of injuries, and we send these out to patients. They're currently hosted on YouTube and they're free domain. So we've got a few other hospitals that are now accessing our videos, and it's absolutely free for anyone to use across the NHS. I'm just going to show you parts of the video just so you can see and understand the quality of it. We won't be able to watch the whole thing.
Welcome to the Virtual Fracture Clinic, an innovative way of managing acute orthopaedic injuries. My name is Lucy Arnott and I am an extended scope physiotherapist. The Virtual Fracture Clinic has successfully managed thousands of patients using virtual consultations and a shared care approach. Our objective is to provide you with high quality information so that you can best manage your injury and reduce the need of coming into hospital. We have designed this protocol as evidence suggests that patients typically only retain 10% of the information given to them in the traditional clinic setting. We understand that having an injury has a significant impact on your life, so I've designed this video series to explain to you the type of injury that you sustained and to guide you through your rehabilitation and management from the comfort of your own home.
Hi, I'm James. I'm an orthopaedic consultant and I regularly manage patients with your type of injury. I'm here to guide you through the details of your injury, the treatment required, and give you your recovery plan. You have sustained a fracture to the base of your fifth metatarsal, as demonstrated now on the screen. This is a common injury and it will heal itself naturally with the passage of time. This normally takes approximately 6 weeks. Pain and swelling are present in the early stages and can be present for 3 to 6 months. You may need to take painkillers or anti-inflammatories, especially in the early stages. The swelling is often worse at the end of the day, and elevating it will help. Guidance on further initial management will be covered by Lucy later. You can walk on your foot as the pain allows, but you may find it easier to walk on your heel, especially in the early stages. You will have been provided with a boot. However, this is for your comfort only and is not needed to aid the healing. This should be worn for the first 3 weeks, after which you should wean yourself into your normal shoes. We do not routinely follow up patients with this type of injury. If, however, after 3 months you're still experiencing significant pain and swelling, then please do not hesitate to contact us for a further consultation. We would also like you to contact us if you're experiencing significant pain or symptoms away from the site of the injury. One of the only things we know that can slow down healing is smoking. If you do smoke, it would be advisable to stop, at least for the duration of the healing process. Further information on how to stop smoking can be found on the NHS Smoke Free website or be obtained from your GP. You can start driving again when you can comfortably perform an emergency stop and use the clutch. Obviously you can't drive if you're still being managed in a boot unless it's your left leg and you've got an automatic car. You can return to work when you feel comfortable, and sports can be resumed at 6 weeks. Bear in mind though that pain and swelling can be ongoing when you resume impact activities. I'm now going to hand you back to Lucy, who will guide you through your rehabilitation.
We're now going to show you a few exercises which will help you to recover from your lower limb injury. The first phase of your rehabilitation is about managing your swelling and acute pain.
Okay, so you can see that sort of mimics what you would have received if you had a face-to-face appointment, but you have the benefit that you can take that home with you and you can watch it over and over again. So more elderly patients who potentially have recall problems, they have that then to review, their family can review it, people who didn't attend the appointment in the first place have that information readily available. We also collect information on sort of patient satisfaction of the service. You can see we collected it before, so to do a comparison of how patients feel this. We do this currently automatically on SurveyMonkey. Every patient is invited to automatically reply to their emails, and we found that 85% of our patients gave us an 8 or above when asked the question, was this an effective way of managing their injury? And did you have a good understanding of your planned rehab? 85% of patients said yes. If you remember when James was speaking, that was 44% before, so that's been a really significant improvement. Also, the one I quite like from me and my team is that lots of people found us friendly, knowledgeable and able to ask questions, which always is a nice one, and that 91 and 94% of patients found that our rehab videos and our shared care plans, which is the written version of the video, were really useful in terms of their rehab. We also have an NHS family and friends score, which I always think is a bit of a strange one to use because you don't wish a fracture on your family and friends. But to get 78% is actually really high in terms of other comparative things within the NHS, and especially on SurveyMonkey. It's the top quartile of all the results collected on SurveyMonkey. So when we're looking at our performance, we looked back at 2015's data, and when James said at the beginning what were our first 4 objectives, we benchmarked ourselves against these objectives. And last year we treated nearly 5,000 patients, and 100% of those patients' x-rays were reviewed by a consultant. So you've got a consultant at the highest level reviewing your x-rays, which didn't happen when you came to traditional practice. If you came in on a Friday and they were struggling at the end of the day, you could have had a house officer who was called off the ward just to get through the volume, whereas everyone's getting high-level care in this model. The second is that we looked at an audit in terms of our follow-ups. So patients who we did want to have a follow-up with, we said, okay, we're going to set a time frame, I'm going to set a correct clinic. So you've injured your shoulder. The first appointment you're going to see is a shoulder specialist, and as a therapist and the consultants, we determine the correct time frame. So we've audited this, found we were doing really well, and people get to be to the right clinics, we were booking in the right places, but then we were slipping a little bit in terms of our time frames, plus or minus 7 days. But the fact that we were measuring this automatically meant that we could present that data as a business case, especially for the shoulder clinics, because that's how we were struggling, to get more shoulder consultants into our clinics. And actually by collecting this data, we were able to really use it to prevent delays in those clinics for the next year. Like I said before, we've got 27 rehab videos online, we're working for more for the hands. We've got 7 research papers that are currently in the pipeline. The most amazing thing about the service and the way that it's kind of saving money is that out of all of the patients referred to us, only 37% of those patients needed to come back to see a consultant, and 6% came back to an ESP clinic, which means that 75% of our patients referred to us virtually never have to come back into hospital after going to A&E. So last year it saved the NHS over 300,000, and since we've been running for the last 3 years, we're now at 750,000 just in Brighton. So if you imagine if the services is spread across the NHS, how much of an impact these savings can have on a national scale. So I'm just going to mention a little bit awards here. So we've been very lucky this year to win 2 national awards. One at the beginning of the year was the NHS Innovation Awards, and then later in the year the AHA Awards. And I really see awards as leverage. So I don't know if any of you guys out there have a system that you're working on that you think is brilliant. Awards are the way to get recognition and leverage to get you further. So by applying for these awards, I got sponsors, 3M, for 6 months, which was really helping. I'm going to show you how. We got links in with Microsoft so that we can start to develop the software to support the future. NHS England come to our mentoring meetings, and we were written about in The Guardian last week. So by applying for these prizes, this has really produced a leverage for me to be able to move forwards with the projects. So we joined up with 3M in a mentorship program as part of the prize, and when we went to a pitch, I pitched this slide to them. It's got a few little additions, and saying that these were the 3Ms that we really wanted to get from them. And over the last 6 months, I can say we've really got this support. So we wanted mentoring. So within the NHS, I don't know you guys, how hard is it to access anyone to mentor you that has any experience in business development or strategy or how to improve things? It's really, really impossible. So going outside the sector of the NHS, I found this to be massively valuable. We also wanted to look at merging care across the South East, and in the last 6 months, we've now got both of our neighbouring trusts either have hired or are in the process of setting up their virtual clinics using our exact model. So in 6 months, we're really managing to corner the South East region. And I want to maximise the reach that we can have on patients, because I truly believe it's a better service for the patients that we're serving. There are some barriers within the NHS, I'm sure everyone knows about barriers. One of the big barriers is lack of central tariff. So I don't know if anyone knows about tariffs, but there's a lack of any kind of central tariff for virtual clinics. So the incentive for people setting these up is very difficult, because the clinicians are like, okay, we want to go down this route, but the commissioners, there's a bit of a difference between what commissioners want to pay for the service and how we can show how valuable it is. And then if every single trust has to then negotiate with the CCG locally, just think about the manpower and the time that that's taking on all of the individual levels, and wouldn't it be better to have it as a central way? And trusts, think about the loss of income. So I said about the 300,000 earlier, that's savings to the NHS and in effect the commissioner's pocket. It's not saving to the trust because there's a lot of direct revenue in. So it's quite hard from trust to kind of look at this model and go, okay, we think this service is really good, but you're going to lose us an income of this amount of money. But what we say is, okay, rest directly your bank balance will have less coming in. But those consultants who've been trained to be doing expert jobs can then be redistributed to work in theatres or can do elective cases that have higher income generation. You're not having to have the nurses in clinic to support that. There's no notes that get tracked. There's no front desk, there's no receptionist, there's no admin costs. So the amount that you save is actually way bigger than the loss of your income, but that's kind of a harder thing to try and sell. I'm kind of working on the logistics of that at the moment. So this is where we've kind of been from, and the future is where it really gets exciting. So as you've noticed before, I've used YouTube for patient videos, which is actually quite good because patients are used to using YouTube, and SurveyMonkey for their outcomes in an Excel spreadsheet to collect my data. That's the one where the real problem is. So this is where we've gone in with a joint ventureship with Microsoft to build a portal technology so that we can have it all hosted in one place. So we talked before about having an electronic referral form, but this one is even better. So you know the autoresponders, you're all used to them within your email, they happen automatically. This referral is now going to have autoresponders. So if the person referring you says, yeah, okay, you're all over the 65, you automatically get our osteoporosis guidelines sent to you directly without us having to do anything. And if the automation says it's a lower limb injury, before you even have your virtual consultation when you leave A&E, you will have an email waiting in your inbox that gives you personalised information about how to manage that acute injury, which gives you rest, ice, elevation, simple exercises. And plus, even better, if A&E said that they gave you a boot or crutches, you get a video in your inbox of how to use the boot and crutches, because we know A&E departments have no time to do this. So patients go home in boots and crutches and like, I don't know how to use these. So as soon as you get home, you've got an email waiting in your inbox saying welcome to your portal, and it has the specific information about how to recover from your injury before the consultants even had time to review your case. And now we have a lovely glossy operating system. So instead of an Excel spreadsheet where someone can accidentally type over your patient records, we've got an integrated system where we can keep track of everything. So different users can log in, they can pull off people that they're going to be making phone calls for, and track everything automatically, which is quite exciting from our point of view. And this will also be automated so that when the consultant has a diagnosis and says, yes, this patient's got a base of 5th metatarsal fracture, again, ping, an email goes out to the patient automatically to give them the right rehab videos. The therapist doesn't have to physically write them an email. It's all automated. So this is just the idea of the quality of the patient information that they would receive. I've had to kind of shrink it down a little bit, so don't read the fine details. But you can kind of see that they get a stream of text with integrated videos, so that they can see all the information or they can choose to read it, depending on whether they're kind of more of a visual or whether they want to consume it or passively through video. We're also going to have some outcome scores on there so that patients can rate us automatically. We don't send them off to SurveyMonkey, that doesn't look particularly professional. They can do it all within their portal. And we're also going to automatically collect patient outcomes. Okay, so when you're referred to the clinic, depending on the injury that you have, it will be coded to say, okay, we need to fill in this outcome measure. So if you're an upper limb injury, we're going to get a pre-injury dash score. We'll then get the dash done again at 6 weeks and then again at 6 months, so that we can start to look at trends of how patients are recovering from specific injuries, so that we can make our response even smarter and develop our service further depending on what our patient needs are and how well they're doing. So the key is with virtual clinics is we need to move away from stick drawings, one-to-one costly consultations, by working smarter and harder for doing a one-to-many model by using digital technology that we have at a lesser price. This is my favourite NHS innovation method slide. I don't think I've seen it anywhere else today. So, any questions? I'll put it out to the vast audience. Yes, I think we've got a microphone for the questions.
Yeah,